Welcome to this satellite session. This session will be in 2 languages, so there will be simultaneous translation provided in the room and also through the web streaming. So those who are joining online, they should join either through Russian or English channel. So this will be a WHO Europe satellite session dedicated to good examples in person-centered care models for people who use drugs. And I would like to invite Dr. Nicole Seguy, who is the unit lead for HIV, STI, and
Recording
viral hepatitis.
In progress.
STI and viral hepatitis at WHO Regional
Recording
Office
stopped.
for Europe. Nicole?
Thank you, Antons, and good morning, everyone, and
Recording in progress.
To this WHO satellites. As Antons explained, the aim of the satellite today is to share good practices of people-centered services for people who use drugs from various countries in our region, and you'll see we'll have very interesting presentations. We also aim to discuss the actions needed for WHO member states and partners to strengthen the comprehensive integrated care for people who use drugs. As you may know, we are updating our global and also regional strategies for HIV, hepatitis, and STI. So we'll have new strategies from 2022 to 2030, so to the elimination goals. And one important part of this strategy will be about providing better people-centered care, including for people who use drugs. So I will start this session not with slides, but just I will speak about what is people-centered care and why it is important for people who use drugs. Integrated people-centered health services is about putting people and community at the center, not the disease. And it's also about empowering people to take charge of their own health rather than being passive recipients of services. Integrated people-centered care is also about organizing services to address all the needs of people in a comprehensive and coordinated manner. For people who use drugs, you know that WHO and other organizations have defined the comprehensive package of intervention to support people who use drugs and address their vulnerability to HIV, but also to viral hepatitis, STI, and TB, and other needs. And this comprehensive package includes not only needle syringe exchange program, opioid substitution therapy, but also HIV testing, counseling, antiretroviral treatment for those who need it, prevention and treatment of STIs, condoms, also prevention, vaccination, diagnosis and treatment for hepatitis, prevention, diagnosis and treatment for TB.
Recording stopped.
We're talking more and more, and it's very, very important to address mental health issues, psychological support, social support, and lately we have also integrated the provision of COVID-19 vaccination. So you can see that this package is really broad, address diverse needs, health needs, and also not only health needs. And that's what we called people-centered services. Optimally, these services should be provided in the same place by a multidisciplinary team. That's what we call the one-stop shop. And you may see some presentations today about that. But while we have really good examples documented in the region, we still have many challenges arising from the verticalization of disease-specific programs, the lack of coordination between services, and often a paternalistic and stigmatizing attitude from healthcare providers toward people who use drugs. So our health systems are not yet fully ready and tailored to provide people-centered services. We will need critical adaptations, including better linkage across services, task shifting, training, and also legislation changes to allow non-expert staff and lay workers to provide specific services. So there is a critical role of the community in providing people-centered care for people who use drugs. And these community-based services have the great potential for providing all services in the same place without discrimination. So these community-based services should be adequately funded, sustained, and scaled up. Addressing all the needs of people who use drugs through people-centered care will improve survival and quality of life of people who use drugs, and also reduce transmission of HIV, hepatitis, STIs, and other issues, and TB. So without people-centered services, it will be difficult to reach our elimination goals. So that was my point to introduce the topic today. And I will leave the floor to Stela Bivol from WHO to present the vision for the regional plans for HIV, hepatitis, and STI 2022-2030 in the context of the WHO European Programme of Work, and how to promote people-centered services for people who use drugs. Over to you, Stela.
Thank you, Nicole. Thank you, Antons. Good morning, dear colleagues and participants, and I'm pleased to join the satellite meeting. I will start from a personal take on harm reduction. Just as many in the audience today, I'm a child of transition, and I remember vividly the hardships of the 90s, when the whole world crumbled around us and 300 million people in 15 new countries had to survive for years until the economy became somewhat
Stella,
better.
Can we ask us to speak a little bit slower, because the interpreters have some issues with the sound, so they would prefer if you could speak slower. Thank you. Sure.
Those were also the times of freedom when everything was possible. So a school classmate, Cornell, started using drugs and dropped out of school after 9th grade. Years later, I saw Cornell one last time, emaciated, avoiding eye contact. He died of preventable causes in his early 20s. Our classmates were quick to blame him for how his life turned. And it made me angry, as if 13-year-old was fully responsible for his choices. In those years, it could have been any of us. Next slide, please. So in 2000, I started coordinating the first national-wide harm reduction program in my country. It proved effective. We succeeded to prevent many more people becoming infected with HIV than in any other parts of the region that did not have access to this life-saving approach. Seeing firsthand how people got a chance to survive simply through providing access to syringes and basic services made me choose career in public health over medicine. So fast forward to 2021. From a narrow definition, harm reduction has become mainstream, recommended by technical agencies and recognized in national government policies in 25 out of 29 countries in the Eurasian sub-region. And needles and syringe programs are available in 7 countries, and opioid agonist therapy in 26. We have also evolved from a narrow definition as synonym to NSP towards recommending comprehensive services for people who use drugs that address access, prevention, and treatment cascades, just as Nicole has outlined, as well as structural barriers related to stigma, human rights, and legal criminalization of behaviors. We also have a good theory of change. Next slide, please. Yes, in this context, we know what people-centered services mean for people who inject drugs, and Nicole went into details of that. The aspiration is that systems of service delivery should be able to address these complexities through closely linked or integrated services. Strategies have been well defined in WHO consolidated guidelines: integration, decentralization, task shifting, community-based approaches, and differentiated service delivery. All are recommended strategies to improve access, acceptability, affordability, and equity. The issue in the eastern part is how we get there. So if my classmate was still alive in 2021 and in contact with a good harm reduction program, he would have had regular access to NSP, either through fixed site outreach or in pharmacies, access to opioid agonist therapy, condoms. He'd be linked to testing for HIV, hepatitis, TB, most likely in a facility. If he had any of these conditions, he'd get treatment. He would have to run around different health facilities to get all of these services, but there may be a case manager still paid by the Global Fund to help him navigate as well as access social support. In COVID times, he'd be even able to get some of these services online and delivered as self-test or ART at home by an NGO. Also, if he had MDR-TB, he would be able to get the video-supported treatment rather than stay in the hospital or come to clinic every day and get all oral drugs instead of a daily injection. But he would be in a minority, as only a fraction of these estimated 3 million people use drugs in Eurasia sub-region, access to all these services by themselves without some support. And the number of countries with successful and comprehensive programs in the highest burden countries are still few, and they make as case studies. But they are largely dependent on donor funding. When donor funding is reduced, the programs shrink and even disappear. So at the national level, in any of the countries in Eurasia region, implementation challenges of these models persist, and we know them all. It's limited coverage, fragmented services, limited domestic funding, persisting barriers, and restrictive environments. So despite the excellent guidance and external funding over 20 years, and as donors expect countries to take over, we have very few examples of countries who manage to integrate all these service models in their health systems, and few in these that are able to answer the three questions. What is the model of care? How are and how will services be funded? Who are the providers? Next slide, please. Next slide, yes. Because of insufficient program scale, new infections continue to increase in the region and mortality has increased. And it is still, next one, it is still mostly an epidemic of key populations, and almost half of infections in the regions are among people who inject drugs. It is an epidemic of my generation, as 85% of cases are among men and women 25 to 49 years. Next one. So despite much better availability of testing and treatment services, the eastern part of the region is still far off track from reaching 2020 targets. And on December 1st, we'll hear by how much. Next one. And compared to HIV cascade, access to hepatitis C testing and treatment is much more reduced despite a much higher prevalence among people who inject drugs than HIV. And the next one, to sum it up, in 2021, we have sufficient institutional and human resources and accumulated know-how, but we lack in the region, what we lack in the region is sufficient will to do it at the necessary ambition to achieve impact to reduce communicable diseases. There's also change in the landscape that puts more pressure on both resources and will. And while the programs still struggle to reach the unreached, COVID has slowed them. With donor presence reducing, countries have a hard time to maintain the gains and struggle to make community-based approaches as part of domestic offering. And in many countries, the efforts to decriminalize behaviors and reduce barriers are ineffective due to increasing resistance. But there are also new opportunities. COVID demonstrated that health systems can adapt rapidly when they have to. For key populations, more online service delivery can help reach the unreached in new ways. There are also technological advances that make testing and treatment simpler and more accessible. We hear more often about renewed hopes for an HIV vaccine and cure, and long-acting formulations of PrEP, ART, etc. This will significantly transform the way services would be delivered and calls for focus on making health systems adapt on new developments. Next one, please. So in this context, WHO Regional Office for Europe has started the development of the Regional Action Plan for HIV, viral hepatitis, and STIs for 2022 and 2030. And informed by a regional consultation in June this year, it is the first plan that brings all of these three into a single document. Its goals are aligned with SDG 3 to end AIDS, viral hepatitis and STIs epidemic as major public health threats, but also with a European program of work towards better health and well-being. Next one. Some of the strategic shifts relate to opportunities of bringing 3 programs areas together. Shift towards people at the center, leaving no one behind, and the lens of primary care reinvigoration, sustainability, increasing focus on health systems, and COVID as an accelerator of both systemic changes and technologies inform priorities. The next one. In light of this, regional action plan includes a stronger focus on health system and policy response to internalize all these shifts and nest HIV, hepatitis, and STI within health systems. But there should not be a one-size-fits-all, but country-tailored approaches to design service delivery models that make sense for its people, providers, and systems, and are based on disease burden. It is more intentional to support countries to translate integration, decentralization, simplification tasks into practice as countries strive to increase scale, but also take the road to elimination. This transformation needs to have adequate resources, including financing, workforce, health commodities, diagnostic and lab services, and strategic information that are well integrated and upgraded in the overall health systems. Finally, this is only possible through a partnership with communities and other partners and a strong leadership. Clarity on the future of disease programs coordination is important, as high burden countries will reach epidemic control in this decade. Therefore, the key audience for this strategic direction are key decision makers on service organizations, funding services, workforce, and technologies. These are governments, ministries, and agencies. So this strategic direction is to address the will and the resources. The next one. Then strategic directions 2, 3, and 4 related to disease-specific chapters will delineate the targets, the key populations, and the interventions to improve continuum of care, and will address the disease programs and program partners. So these strategic directions will address the know-how. And finally, the last slide, let me attempt what this vision would have meant for Cornell if he had lived until 2030. By 2030, my classmate would have been in his early 50s. Before he turned 50, he would have cured his hepatitis C, would have been on ART using a simpler regimen of 1 pill a day or less frequent, hoping for a cure by 2030. Thus, his early life injection-related consequences would be in the past. He would also have cured his MDR-TB with pills, not injections. His addiction would have been controlled using long-acting agonist therapy or some new method. His running around different health services and sites would have stopped. For health, he would see his primary physician for his regular checkups and sometimes other providers for his age-related chronic conditions and mental health. No one would judge him. He would be able to work, catch up on lost opportunities early in life, and enjoy his family. He would not know all the work behind the scenes to make it happen, including thinking through service models, payment mechanisms that are adequately reimbursing providers, setting point of care multi-disease networks, electronic patient records, all of this allowing seamless care. And obviously, in addition to his own better health and well-being, he would have been able to witness better social and economic situation and better environment as SDGs become within reach in his country. I hope we all live to see this happening in our lifetimes and work together to achieve it. Thank you, and apologies for all the delays. Over to you, Antons.
Thank you very much, Stela, and I apologize very much for technical issues, also because of the delay, because of the speed and everything. But you know, this is the first session of this conference, and also the first time we are trying this hybrid approach. So I think, thank you very much, Stela. It went well. So if there are no questions to Stela at this point, maybe we should proceed next to our program. So we will have several presentations of good practices of integrated care models for people who use drugs in our region. And the first presentation will be from Dr. Lars Peters from CHIP, Copenhagen Center of Excellence for Infections and Immunity. And he's a senior researcher there, and he will present the the shared care project in Copenhagen. Lars, can you share your slide? Do you want me to share your?
Yeah, I can try, but I was not successful before.
Okay.
Can you see?
Yeah, I think that's fine, and it's easier if you can control. We can see the slides in the
Okay.
room. Thank you.
Okay, so then I'll just start right now. So thank you for the invitation to present the SAC program. SAC is short for Shared Addiction Care Collaboration, and this is a decentralized hepatitis C shared care model in Copenhagen, with the aim of decreasing hepatitis C-related transmission, morbidity, and mortality among injection drug users. Before SAC, drug users in Copenhagen and other parts of Denmark enrolled for drug addiction treatment. They had to go to a laboratory for testing for viral hepatitis and HIV, and if they were positive, then they were referred to a hospital for further evaluation and treatment. And that resulted in low testing rates and low linkage and retention in care for hepatitis C, as shown here for drug users in Copenhagen in 2014. So the SAC was a 3-year project running from 2014 to 2017 that involved all addiction treatment centers in Copenhagen and 2 infectious disease departments, and then my research institution, CHIP. And the aims were, as mentioned, to develop and validate a model for decentralized hepatitis C care and treatment in Copenhagen, and to increase the uptake of hepatitis C testing and linkage to care in order to reduce the hepatitis C-related morbidity and mortality among drug users in Denmark. After the project ended in 2017, the model for hepatitis C care is now offered as routine care in Copenhagen. Basically, the SAC model for hepatitis C care moves all testing, further evaluation such as fibroscanning, and hepatitis C treatment from the laboratories and hospitals to the drug addiction centers. The only role of the hospital doctors is to prescribe the medicine and to monitor the blood test during treatment and after treatment, but they don't see the clients at any time points. The SAC database is a crucial component in this model. The database serves as the patient chart and the tool for communications between the hospital and the drug addiction centers. In Denmark, all individuals have a unique personal identification number, and all laboratory tests and test results are digitalized and linked to this number. The SAC database can in real time merge all hepatitis C relevant laboratory data into a single database by pulling data from the primary data sources via the Danish Health Data Network. Some data like FibroScan results are manually keyed. So the database, here's a screenshot from the database. The database provides an overview of the hepatitis and HIV status of the individual, but also an overview of the entire population that the drug addiction centers didn't have before. Clients are offered annual testing for hepatitis and HIV, and the database then creates a PDF file with interpretation of the results and a plan for further follow-up, which is sent to the addiction center via the database, and then they will follow the recommendations outlined in the file. If hepatitis C treatment is considered, there will be an assessment of treatment adherence with input from both healthcare and social care workers, the people who know the clients the best. When treatment is prescribed, you select a plan for monitoring that is tailored to the needs of the individuals. All this is, you see here is of course in Danish, but if you have questions to it later, then I can answer them. And here are some results. During the 3-year project period, the hepatitis C testing rate increased from 43.6% to 66.2%. And that was the population that was enrolled at the time of treatment project start in 2014. It was 1,875 individuals. And the number of new chronic infections in this population detected increased by 208 cases. This is the green line here. And these numbers has further increased after the project was completed. When it comes to hepatitis C treatment, then during the project period, treatment with DA therapy in Denmark was restricted to those with advanced fibrosis, which meant that only 15 people were treated and 14 of them were cured. Since then, treatment has been offered to all in Denmark, irrespective of fibrosis status. I don't have the exact number of people treated, but as of today, we have 424 individuals in the database that are previously hepatitis C RNA positive, of course, an indicator for treatment in most of them. So what are the perspectives? As mentioned, the SAC model for hepatitis C care has transitioned from a project to routine care in 2017, and it's now also includes drug treatment centers in the suburbs of Copenhagen. There's ongoing work still with the Danish health authorities to explore possibilities of disseminating the SAC model to other municipalities in Denmark. And importantly, this model is generic, which means that it can be used for other diseases, other infections that could benefit for a collaboration like this. So these experience with breaking down barriers that we have, it can be used for other chronic conditions, not only infections, it could be diabetes and so on. And that was the end of my presentation. Thank you very much for listening.
Thank you very much, Lars. So we saw one of the early examples when hepatitis C treatment was integrated into the drug treatment services, and we can see it was successful and was further extended to other clinics in Copenhagen, and their plans for a national rollout. Lars, can you stop sharing the screen so we can? Thank you very much for your presentation, and if you stay for the panel discussion, we'll be also very grateful. And the next presentation will be from Portugal, from Silvia Busi, who's a harm reduction worker from GAT IN-Mouraria project in Lisbon. So it's another well-known and quite famous example of low threshold services, where all the services basically are put together for the people who use drugs. Silvia, can you share your slides?
Yeah. Good morning. Thank you for the invitation and the opportunity to present. Okay. So, as you introduced, we are a harm reduction center located in the city center of Lisbon, that is directed for people that use drugs, but our doors are always open. Our main characteristics are that we are low threshold. Our access is free of charge. Our team is a multidisciplinary team. We have peer workers, harm reduction workers, nurses, social workers, doctors and psychiatrists, and soon also a psychologist. And we are open 5 days per week, 6 hours per day. We offer different services. We offer snacks, hygiene product, and clothes, as our clients has hard access to these items. We also help for the communication. We offer internet connection. Before COVID, also a laptop that they could use. Now we can't, but we hope soon we can offer it back. We also offer phones for them to make calls, and we offer our address for them to receive their posts. We offer kits to injection and smoke use of drugs. We offer needles, syringes, crack and cocaine pipes, and other materials. We also offer inner and external condoms and lube. Our center is a place where we can talk, discuss about a lot of different topics, not just harm reduction and safe drug use, but also sex education and other topics. We offer nursing and doctor appointments, psychiatrist appointments, and soon also a psychologist appointment. And since September 2020, we started HCV treatment in the community. We also have social workers that help our clients with housing, finding where to eat, access to food, and make documents and other things. As I said previously, this is a little bit of the material that we offer. We also offer information about harm reduction and drugs and STIs. We have a service of testing for HIV, hepatitis, and syphilis. This testing service is targeting for people who use drugs, but is open to everyone, to general population, everyone that want to get tested. The tests are performed by health professionals or trained lay workers as peer educators or others, and they are free, anonymous, and confidential. This is our intervention model. We work through activism and research. We're starting by information, prevention, harm reduction, then go to testing and link to care or to treatment in the community. Another really important work that we do is the peer support that starts through peer education, peer escort to health and social services, case management, and social support. Our harm reduction center works to promote a safer drug use and access to social and health services, the participation in the community for people who use drugs, to promote the rights and dignity of people who use drugs, and also always is based on research and evidence-based practices. Our clients, these are the data from 2020. Most of them are men, unemployed, 40 years old or more, that have less than 9 years of education. Most of them are Portuguese and in situation of homelessness. 24% of them inject drugs in the last 12 months. And the main drugs that they use are cocaine, crack, and heroin. But also we are seeing an increase of the use of benzodiazepine. In this year, from January to October, we had 306 registered clients that come frequently, 36 clients per day. Unfortunately, this number decreased due to the pandemic, but we are seeing that they are coming back. This number is increasing since September in the last 2 months. We did the 285-hour testing section, and we distributed a lot of injection kits, crack cocaine kits, condoms. We did 138 peer escorts to social and health services, 747 health appointments, and 1,417 social appointments. These are also the data from this year, since January to September. We performed different tests, mainly HIV and HCV, and we could detect 1 HIV reactive test, 22 HCV, 4 HBV, and 6 syphilis. And as I said previously, since September 2020, we start the HCV treatment in the community. This treatment we started because for the goal to narrow the gap between the Portuguese national health system and people who use drugs. We could reduce the number of appointments with the healthcare professionals required now to 4 or 6 visits, or 4 or 5 visits, and reducing barriers to access healthcare and offering additional support. We also offer social and peer support. And this we saw in the numbers that is working well, because a lot of our clients felt discriminated in they feel discriminated, in the hospitals, or had hard problems in accessing the hospitals, and now it got easier with this consultation. We have 21 people that already concluded the treatment since September 2010 to now. 6 people are currently in treatment, and 78 are included in the consultation, but are waiting for the treatment to come. And another new service that we started in 2020 is our community mental health consultation. That gave us the opportunity to offer easier access to mental health consultation, nursing, social and peer support, and medication support. That means that we provide for the medication and we help in organize the medication better. This gave us the opportunity to identify drug use disorders, as we were expecting, but also to identify mental disorder that were not previously detected, and some of them really serious. And we have this consultation we had this consultation once per week until September, and now we started twice per week with the intention of having more frequently, as it's our clients really research for it. In 2021, we did 213 consultation for 63 people. And soon we will start with also offer a psychologist consultation. We also work a lot with the information and dissemination, and these are 2 examples of activity that we did in the past. Activism is one of the main activities that we do, and these are also some examples of a manifestation that we participated. Peer work is fundamental to help sensibilize about different topics. We also do community research. These are a few examples of study that we took part in the past. And this is a picture of us doing activism about people who use drug rights. And that's all. Thank you.
Yeah, thank you very much, Sylvia, for excellent presentation, and very nice to see the new interventions or the new additions to the In-Mouraria Center, especially mental health. We know now it's a hot topic, and it's also being raised on a high level, also by WHO with the Mental Health Coalition. So I think this is the area where we have to work, and also thanks to this project, we also can see how it can be integrated also in the services for people who use drugs. Maybe not to, we'll be behind of time. I would like to invite the next speaker, and also I want to let you know that next three presentation will be in Russian.
I think this is a great opportunity and great news indeed that all this week we will be talking about issues related to HIV and drug use, and that this is going to be discussed on such a level, and that we can discuss and collaborate together, that we can learn from each other's experience and see what international organizations recommend as well. Now, I want to go back many years to when I was a student of psychology and pedagogy. And during my studies, we discussed the models of how social support is organized and how social services are organized for vulnerable people. And I remember back then we were told that when we organize these services, we need to keep in mind that every person, no matter which vulnerable group they fall into, each person has certain characteristics that are the same, that are something that everyone has. So basically that they are people just like us. But at the same time, they also belong to a very small group of people that we encounter in our societies. And also the same theory mentioned that every person is unique. And this is probably the biggest truth. And this is something that really stuck with me, and this is something that I apply in my work as well. And when I started to learn about healthcare management, this idea really helped me, and it is still helping me to this day. Now, talking about people who use drugs and the importance of having integrated services for these people, we need to keep in mind that people who use drugs have shared human needs. So we shouldn't just focus on needs related to the drug use. We need to remember that these people also need to feel safe and secure. They need to have a certain living standard. They have needs related to their general health, not just needs related to health issues related to transmitted diseases. They can have, for instance, issues related to blood pressure. Also, people who use drugs are characterized by a certain problem, a problem that is created arises from certain life experience and behavior. And this is where we need to take a look at these characteristics that separate these people who use drugs as a group from us. And these are the characteristics that we base our services on, these needs of people who use drugs. But still, again, every people who uses drugs is unique. Every person has their own needs. They have needs that perhaps cannot be related directly to the drug use, for instance. These people can have some sort of other vulnerability, some sort of specific psychological issues or differences. Now, it took us about 20 years as an organization, because we have been working in harm reduction for 20 years. But it took us 20 years as an organization to realize that in order to be efficient, to really affect the quality of life of these people, to give them what they need, and to also have some effect on the epidemic, we need to look broader. Because when we take a broader look, we are able to be more efficient in preventing the HIV epidemic on the city or on the regional level. So what we have been doing since the year 2000, and now I will ask you to take a look at this first circle on the left with the human on top. We were trying to organize and make available all the services that are known to us and that are recommended in various guidelines. We started with the issue of HIV, then we tackled the issue of STIs, and this means information, this means providing clean syringes, condoms, etc. Next, we started on the issue of tuberculosis, because this is a very serious disease that can worsen the health of an HIV-positive person who uses drugs. Next, we started to think about overdoses and other issues. Basically, the first 10 years, we were trying to make these services accessible and to guarantee at least some basic level of quality of these services. For the past 2 years, realizing that people's needs are much broader and that we can have many options how to be efficient, how to improve these people's lives, whether they are HIV positive or not, we realized that we need to take a broader look at the people's needs. So now our approach is changing. Now the approach is shifting to the focus on the person. And the person is at the center of all these services, not their condition. This also means that we have an opportunity to be more stable. Because when we start integration, when we start working with other programs, when we start doing interventions, we can have a complex look of what our clients need. The programs that we are implementing now are various, but in our one center, we try to integrate everything that can be integrated. Our organization is located in Moldova, in Aleksey, and I invite you to visit us. At this center, we offer syringe exchange, we offer testing for HIV, STIs, and HCV. We have outreach workers, social workers. We work with overdose prevention using naloxone. We have group work. We have individual psychological consultancy. We have case managers, psychological assistants. Right now we are starting temporary shelter for women who use drugs. All of these services are under one roof in our center. We try to gather everything that is related to harm reduction under one roof. But of course, harm reduction, that's not just HIV. It's all about how these people function in society, how they are integrated, and what is their quality of life. Lately, we have also been closely following the questions of sexual health. Back then, when there was a true HIV epidemic, and when the disease was really widespread, that was our main focus. But now when we have learned more about the needs of our clients, we have employed a gynecologist and also a urologist for men who use drugs. And of course, all our personnel has been trained on the topic of sexual health. Now, as always, the biggest issue now are psychoactive drugs. And for these people, it is important for them to understand why these drugs are dangerous and what issues can be related to them and health issues, more specifically. Here, our center helps people deal with these questions as well. Where we can, we are trying to professionally integrate our clients, and we also have several lawyers, several legal advisors who help us provide services to our clients and who can perhaps connect us to specialists in the legal world. Now, our goal is to integrate services based on the needs of our clients. That is our key goal. So, an example of integration is integration through organization of services in one center, under one roof. Of course, not everything can be provided from a community organization. Some services are strictly medical, and they are something that only medical system can provide. So what we did in Aleksey, we are trying to integrate them by making them more available and accessible, for instance, by decreasing the physical distance to these services. We have created a special office for psychological and social support. We also offer TBC prevention for HIV positive clients using replacement therapy. Another example I want to share is that we have organized this replacement therapy under the tuberculosis service. This means that we offer consulting and testing. And what we found was that it wasn't really difficult to do this, and not many resources were required, and persuading the personnel to work with us was not that difficult at all. Another form of integration is building collaboration. For instance, we direct patients to health professionals who are not located in our centers, because sometimes our clients do not have access to certain specialists. Currently, for instance, we have a collaborating addictologist, a gynecologist, but also we started working with the police, and where previously we were like, don't intervene, and now we actively collaborate with the police. For instance, in September, we had 28 people, not just people who used drugs, but for instance, people who suffer, who are alcoholics. They were directed to us to receive various types of services. We tested most of them to HIV. They were screened for TBC. We tested them for STIs, and we have 2 positive HIV cases, 3 cases of syphilis, and 3 cases of HCV. And through integration, through collaboration, we can provide these people with prevention services. this service is also available under our center. We are not the providers, but once a week we have an expert coming to our center, providing this service, and the expert on the infection talks to our clients about what analyses need to be done, etc., before they receive PrEP treatment. Now, when the clients go see a physician, the physician then decides whether this is an appropriate course of treatment, and if it is, then the client receives the first treatment on that day in our center, and then they go to regular follow-ups to receive additional treatment. Here is a picture of our center. If we had the time, I would give you a virtual tour, but as I said, I invite you to visit us in person. So what is the base of our success? I'm not going to talk about this too much because I don't have too much time left, but of course this is the potential of the service provider, because you need to be able to coordinate all this, and for that you need trained personnel, you need a good communication strategy, you need a good information strategy to let the community know that these services are available. You need certain quality standards. We do have them. I can share more to those who are interested. You need to have some financing, of course. We are based on grant financing, but also we have services that are financed by local budgets or even by the social security company. This is important because they complement each other and allow us to provide comprehensive services. You need to have synergized programs reflecting various needs of various people. So all resources, financial, personnel resources need to be evaluated and they need to be distributed properly. You also need to integrate the affected communities. This is very important because our team includes community members. And of course, you need to have good environment, because environment is everything when it comes to accessibility of the services. Now, I want to repeat again that individual approach is the key factor in our work. We need to remember that each person has some individual needs, and it doesn't matter that this person belongs to a group of drug users. They still have their individual needs. They need individual approach. And even though we have abundance of technology all around us today, and they are very important, we need to use them too, because they allow us to promote the services and make them more accessible. But still, this human approach, this face-to-face approach, is extremely important, and we need to keep that our main focus, with including technology where appropriate. And I think this is all. So I wish you all good health. Take your vaccine. And by the way, one of our programs also provides information and vaccination for COVID-19 because it keeps people healthy. So this is also a form of integration. All right, thank you.
Thank you, Ala, for your presentation. It was very interesting. We are running a little bit late, but the organizers tell me that we can go 10 minutes later. And our next speaker is Nadezhda Pashutova of the Humanitarian Action Fund. She's in charge of the medical program. The presentation was prepared together with Aleksey Lakhov, who was expected to help facilitate this session, but he only got his visa last night, so he's on his way right now. So that's why we had to improvise. Nadezhda, the floor is yours. Nadezhda, could you please check your mic? We cannot hear you. Can you hear me now? Yes. Hello, dear participants. My name is Nadezhda Pashutova, and I'm head of the medical program of Humanitarian Action. It is a charity based in St. Petersburg, Russia, and I will be telling you about how we integrate medical and social services in a low threshold center. Our key target audiences are people who use drugs, sex workers, and MSM, men who have sex with men. As of today, we have 3 mobile prevention centers. This is our blue bus. It is a mobile clinic on wheels for people who use drugs. It is unique both in terms of Russia and in Europe. Our blue bus offers testing services, syphilis, HIV, and hepatitis testing, also counseling, and needle and syringe exchange program. This is our small bus, that's what we call it. It is a refurbished van which we use to identify locations of our key groups in St. Petersburg. Then that information is communicated to the blue bus. And in the small bus, we also provide testing, we distribute kits, and offer counseling. This is our regional bus. It is again refurbished minibus, offers the same services as the previous 2 buses, but this bus drives around 10 municipalities of the Leningrad region. Here we also have international donors, and this bus distributes kits and tests and provides counseling services. In the summer of 2020, we opened a clinic. It is located in St. Petersburg downtown, close to the underground. It is a drop-in clinic for migrants and anonymous clients who do not have any ID documents. If we look at numbers of drug use in Russia, in 2020 we had 18,000 of intoxication cases, over 7,000 lethal cases. That is 16% more than in the previous year. We officially have 381,000 patients monitored for mental and behavioral disorders related to drug use. We have a certain decrease in this number. Also, the number of registered injection drug use is decreasing. Opioid users decreasing, 120,000 people. Polydrug use and abuse of other substances is growing. We also have 19,000 patients with psychostimulant addiction. This number is growing. We have also witnessed a certain decrease in HIV infection in injection drug users. In our clinic, we have doctors, and our doctors have our license. We have general practitioners, surgeons, otolaryngologists, nephrologists. We also have pediatricians, eye doctors, neurologists, gynecologists, and other specialists. Our center also has a specialist which provides social and psychological support, and our staff also escorts our clients to other clinics in a town if they need to see a Tbilisi specialist and other specialists in town. We provide various support, including social support of our clients. Now, how do our beneficiaries find our clinic? Through mobile clinics, but also we use internet outreach. We try to find our clients on different websites. We use messengers, specialized forums, chats. We're also present in the darknet. We have internet outreach specialists who try to spread information in chats of people who use drugs, also in places where users buy drugs. Also, our clients find us through the law enforcement system, where, for example, people who were released on parole get information about us. Our partner organizations, other NGOs, refer clients to us. Who funds our services? Right now, this comprehensive model has been deployed thanks to Lighthouse, that is Elton John Fund. They provided financing for us from 2018 to 2021. In 2020, we were financed by Médecins Sans Frontières from the Netherlands. We also receive funding in 2021 from the Global HIV, TBC, and Malaria Fund. We also get certain financial support from private donors and from the municipal administration of St. Petersburg. This year we have had 658 medical visits. 83 people receive case management support. Most sought after doctors are general practitioners, venerologists, surgeons, and psychiatrists. That was all. Thank you. Thank you very much, Nadezhda. Thank you very much for stepping in at the very last moment because Aleksey wasn't able to attend. And thank you for your work. And now our final presentation of this session, Konstantin Labartkava from New Vector, an organization based in Tbilisi. It is a very well-known organization that provides comprehensive care to people who use drugs in Tbilisi. They're also a member of the National HIV Elimination Program in Georgia.
Thank you for introducing me. And now, if you allow me, I will share my presentation with you. I apologize, I opened the screen and I can't see my presentation. Could you please help me sharing my presentation? I apologize, I have some technical issue as well. Please give me a minute. Perhaps, Konstantin, maybe you can just talk about what you were going to present, because I think I will need to restart my laptop. So perhaps if you can just start and talk without the presentation. We'll try to make the presentation working in the meantime. You can start, and we'll try to make the presentation working. All right. Hello again, dear colleagues, dear friends. My name is Koka Labartkava. I'm the director of the first community organizations for people who use IV drugs in Georgia. Our organization is called New Vector. And first of all, I would like to extend my thanks to the organizers of this event for giving me an opportunity to have this presentation on the topic of treatment of HCV as a part of harm reduction programs in Georgia. In my presentation, I will talk about our program, about elimination of HCV in Georgia, and also on elimination of HCV in Georgia and related programs. Now, first, I wanted to talk about the demography and how spread Hep C is in Georgia. Georgia is made of 13 regions and 2 occupied territories. The total population of Georgia is about 3.7 million. Currently, Georgia is 5th in the world in the spread of HCV and 1st in the countries of Eastern European region. Based on the results of widespread research that was conducted in Georgia in 2015, there are about 215,000 people infected with HCV, which is 7.7% of our total population. Now, out of these people, over 150,000 people have chronic HCV. So, in total, there are 55,000 IV drug users in our country, and out of those, 60 to 70% are positive for HCV. Anton, how is the presentation looking? Still nothing, huh? All right, I'll continue then without my presentation. As I mentioned, I'm from the first community organization in Georgia. We registered our organization in 2006, and our mission is to promote treatment and integration of people who use drugs in society, including people who are HIV, HCV, and TBC positive. At the beginning, we focused on 2 aspects: advocacy through mobilization of the society in order to humanize drug policy and to make medical, social, and other services more accessible to people who use drugs. Another focus is providing comprehensive services under one roof for people who use drugs, and also for vulnerable people, and in some cases for a general population. Today, New Vector offers a wide spectrum of services in harm reduction, medical and social services for people who use drugs. And I see that my presentation is finally on your screens. Thank you. All right. Let me find where I am in the presentation on the proper slide. Which slide do you need? I need slide number 5. All right. So, as of today, our organization offers a wide spectrum of services in harm reduction. For instance, harm reduction programs, under which we distribute sterile syringes, we provide consultations, we provide an option to be tested for HIV, hepatitis, and TBC and syphilis. We provide fiber scans. We have also introduced antigen tests for COVID-19. We offer confirmation analysis of HCV. We provide tuberculosis screening. We provide an option to consult an OBGYN, psychologist, and psychiatrist. And since 2018, we have integrated treatment of HCV into our organization. We are the only organization in Tbilisi that has also treatment processes integrated in its functioning. There are 3 other organizations like us in Georgia in total. That is, organizations that in their respective regions run elimination program for HCV. Since 2012, our country was not admitting that we have a nationwide HCV problem, no matter how serious and widespread the problem was back then. Back then, we also only had access to old medicines and drugs that were extremely expensive and that had severe side effects. Also, there was almost no information available to the public on HCV, so the general public was very unaware of issues related to these diseases. So people who got infected, this was basically a death sentence to them because they did not know what to do with it. Now, in that time, when it seemed quite desperate, that is when in 2010 our organization, together with others, we have started a campaign, advocacy and information campaign requiring treatment of HCV. We ran an information campaign, we organized protests, we mobilized patients showing their face in media. We were trying to lobby in the government, and we are trying to enter into a dialogue with pharmaceutical companies and government structures. This is our first protest on HCV. This is in 2010 when we and the patient organization HEPA+, we organized this meeting telling the population that 200,000 people are infected with HCV and they are hoping for treatment. We filled stadiums in football matches, and on these football matches, when the stadiums were full, we were also there with our protest signs to be seen by as many people as possible. Our group of activists brought a big banner to attract the attention of the media and the attention of the government, including the president. This was our first big protest, and it was the first time that we were able to attract a lot of attention from media and from the public. This was followed by years of efficient advocacy on national and governmental level. We used different messages over our campaigns. For instance, HCV doesn't discriminate, or protect yourself, etc. Here you can see a picture of us talking to media. On the next slide, you can see some quotations from representatives of international organizations and what they said about us, as well as what government representatives said about us and our campaigns. For instance, the representative of the Open Society Institute says that together with a group aimed on harm reduction in Georgia, we have been actively promoting accessible treatment and diagnosis of Hep C. Over many years, the patient community was trying to draw attention to the problem of Hep C using various forms of protests, information campaigns, and mass events. As a result, they were able to mobilize thousands of patients, and HCV was recognized as a problem, and the government took upon themselves the political promise to resolve this problem. This was an unprecedented campaign for social security. Also, Marian Jashi, the head of the health committee of the parliament, also said something about us, which I'm not going to read here. So please, next slide. On this slide, I want to show some statistics on elimination of HCV in Georgia. This program was started in 2015 on April 21st. Company Gilead provided Georgia for free with up-to-date drugs, and now we are the only country where treatment with these drugs is available to all patients for free. Now, out of all people who have gone through this treatment, over 98% have been completely cured. So you can state that such program to eliminate HCV has not been conducted in any other country in the world apart from Georgia. And in 2019, Georgia received an award for the success of this program, and we were praised for our approach in eliminating HCV. This program was integrated in public organizations and public structures, and we are very happy that this is something that we were able to achieve, that we were able to persuade various levels of governance that this program is necessary. And finally, this really happened. The HCV elimination program was integrated on a general level in the population. Here is some statistics on our participants in the program. It shows that, again, 99% of participants in this program were completely cured. And over the last 2 years, we have confirmed 362 cases of HCV. Out of those, 95% were people who use IV drugs. In total, 221 patients were included in the treatment program. And as I said, out of those, 99% have been completely cured. One patient was not cured. He had an alcohol addiction, unfortunately. Currently, our program includes 31 patients. And on the last slide, I want to shortly describe our plans for the future. As a result of active collaboration with Hep-C Patient Association and Georgia National Center for Public Health and Disease Prevention and Control, we have created new communication strategies and tactics to promote and support the HCV elimination program. Under this strategy, we will have free diagnostics and treatment in 2025 or before. New strategy also includes testing on HCV, prevention of HCV, and inclusion of patients in the process of treatment. The motto of this campaign is HCV will not wait for you. The main goal is to increase the public awareness, to increase disease prevention, and to engage HCV patients and to reduce the number of new HCV patients. And the ultimate goal is to eliminate HCV by 2025. We hope that by involving public organizations, government structures, experts, and the community, and of course patients' organizations, we will be able to reach this target by working together under this elimination program. And once again, I want to thank the United States government and the Center for Disease Prevention for their support, and I also want to extend my thanks to the Gilead company and all people who have contributed to treating and saving the lives of our citizens. And also thank you for your attention. Thank you.
Thank you, Koka. Apologies for the technical problems. Again, it was very interesting to hear about the Georgian elimination program. We all know about it. And it was very interesting that you showed how to integrate diagnostics and treatment into harm reduction programs, and how this can expand the outreach of diagnostics and promotion of such programs.
Questions from the audience, we'll be too happy to take, and I will forward to the speakers. Otherwise, if there are no questions, then I would like the speakers to say one take-home message from this session. So why integration is important, what are pros and cons, what does it mean for people who use drugs, or whatever you mean. So please be brief and we welcome your final thoughts. Over. Nicole, would you like to start? We don't hear you.
So maybe Antons, let me try to, do you hear me well this time?
Yes.
Okay. So I will be very brief. I think we had the chance to hear about the experience and good models of people-centered care and integrated care for people who use drugs, and how they have evolved over time from narrow interventions to comprehensive and addressing full range of needs. So we don't need to reinvent the wheel. We need to work with governments to bring this to scale and make them part of health systems. Over from me.
Thank you, Stela. Lars, would you like to say anything?
Yes, thank you. So I just want to say that the former model, if you can call that, of hepatitis C care was based on that the drug users, they had to adapt to the system. So I think we have so much evidence that that doesn't work. So the systems need to adapt to the needs of the drug users instead. And I don't think there's one size fit all, because we have heard many different models, and some models work better in certain countries. So each country should look at their own situation and then develop a model based on the population in that particular country or town or city. So I think that's my message.
Yeah, thanks a lot, Lars. Yeah, maybe I will also try to finalize, because we really need to end this session. I think we have seen really different examples from different countries, like really different countries in the region, from the countries in the West and the countries in the East, like Russian Federation and also Republic of Moldova. And we can see that these models of integrative care, they really work, and we need to see how we can adapt them in the national context, as Lars also mentioned. And I think we will think and we'll use those examples also to promote the people-centered approach, and also returning to the initial objective of this session. So we will definitely take the lessons learned during the development of the new action plan, and I think it was really nice to hear, despite all the technical difficulties. And I would like to thank once again all the presenters and the audience for patience and also for your interest. And so this is just the beginning, and wish you a very fruitful harm reduction conference. Thank you. Over.
Thanks.
Thank you.